I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospitals. You may call me an AIDS dinosaur who has followed the HIV epidemic from the very first cases in the early 1980s through the triumph of antiretroviral therapies, a triumph unequaled in the annals of medicine. This triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases and the myriad manifestations, hence the idea of these videos. After a short introduction, they will show a series of images illustrating one or several exemplary cases from my files. By lipodystrophy, we mean body habitus changes associated with HIV treatment. There are two distinct manifestations which may occur together: fat loss in subcutaneous tissues, lipoatrophy of the face, legs, arms and buttocks, and fat accumulation in central areas, lipohypertrophy in the abdomen and intra-abdominally, breasts and neck. These changes are associated with insulin resistance and hyperlipidemia. Lipoatrophy is caused by thymidine analog nucleotide reverse transcriptase inhibitors, NRTIs, such as zidovudine and stavudine, whereas lipohypertrophy has been associated with protease inhibitors, but this association is somewhat doubtful. Two examples of lipoatrophy with loss of subcutaneous fat in the face. This is easily recognizable and cannot be hidden. Many patients fear discrimination. Subcutaneous lipoatrophy with prominent veins, not to be confused with varicose veins. Lipohypertrophy, gynecomastia and, quote, buffalo hump, unquote. Truncal fat is increased, but note the relative atrophy of the buttocks. Many patients complain of discomfort when sitting for a long time. The patient whose CT scan is seen on the left had a 11 kilogram weight gain and abdominal discomfort while on 2 NRTIs and ritonavir boosted atazanavir. Compared to a control patient right without lipodystrophy, accumulation of intra-abdominal fat, these are the dark areas, is evident. Mammary hyperplasia combined with marked fat loss in the legs and face. The face is not shown for reasons of confidentiality. Growth hormone can reverse some of the effects of lipodystrophy, in particular lipohypertrophy. At baseline, this patient had a prominent abdomen and intra-abdominal fat accumulation, blue areas, which largely disappeared after 12 weeks of treatment with recombinant human growth hormone. Newer treatments without thymidine analog NRTIs do not produce lipoatrophy. However, established lipoatrophy is difficult to reverse. Cosmetic surgery may offer a partial solution, as shown here with polylactic acid implants. All antiretroviral drugs can cause drug rashes in decreasing order of frequency: Nevirapine, efavirenz, Abacavir, antiproteases, 3-TC, FTC, etc. So can the drugs against opportunistic infections, in particular cotrimoxazole. There is a continuous spectrum from the trivial to the lethal: drug rash, the DRESS syndrome, which is drug rash, eosinophilia and systemic symptoms, up to toxic epidermal necrolysis, TEN, which can be subdivided into Stevens-Johnson syndrome with about 5% mortality and the Lyell syndrome, with much more elevated mortality. Here is a typical example of a maculopapular drug rash, partly confluent over the knees, due to cotrimmoxazole in a patient with pneumocystis pneumonia. A similar rash to the preceding, but the offending drug is here efavirenz. This was a 24-year-old drug user with heroin and cocaine. He was hospitalized because of an acute psychotic episode in April of 1998, found HIV positive with 220 CD4 cells, a viremia of 56,000. He was started on Abacavir 3TC and zidovudine. This is Trisivir. But she was convinced that people were poisoning her and was transferred to the psychiatric hospital, where she developed fever to 39 degrees, a rash, and vertigo. She was found to be hypotensive with a blood pressure of 80/50 and sent back to the medical ward, where the liver enzymes were also elevated. Note the confluent rash on the patient's back and legs, reminiscent of a sunburn, the typical maculopapular rash on the arms, and the edema of earlobes. Of 48 people with a B5701 antigen, 23 had Abacavir hypersensitivity. But of 794 B5701 negatives, none were Abacavir hypersensitive. In other words, Abacavir hypersensitivity only occurs in patients with HLA B5701. HLA testing is now standard practice before Abacavir administration. Nevirapine is known for more frequent and more serious skin reactions than other NNRTIs. When used in pregnancy to prevent mother-to-child transmission, cases of fatal liver failure have occurred. Here is a case provided by Dr. Virisantana from Chiang Mai in Thailand. An 11-year-old boy with congenital HIV infection was started on Nevirapine, 3TC, and zidovudine. 10 days after the start of treatment, he developed diffuse skin lesions, including his palms and soles. Mucosal involvement followed of the eyes, mouth, and genital areas, with fever up to 39.5. Here are the typical features of Stevens-Johnson syndrome with a diffuse polymorphous rash and involvement of palms and soles. Mucosal involvement is typical of mouth, eyes, and genitals. Also note the target lesion below the right eye. Thank you for watching, and thanks in advance for your feedback. This video is part of a series on opportunistic diseases in HIV/AIDS. If you are interested, please subscribe or click on the latest upload top left.